Okay. So my name is Melanie Cavalier. I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission. I want to thank everyone for joining our PFAC Lunch and Learn webinar. You can see the title of it there on the screen, Engaging Patient and Family Councils during COVID-19, which is the public health emergency. So just once again, this meeting is being recorded. So I do want to cover some housekeeping items, and then we'll get started with the topics. So I want to let everyone know if this meeting is hacked, I'm going to ask you to please hang up immediately. Alana Sutherland will send an email to everyone who registered for this webinar with a new meeting link that will allow you to log back in. So please contact Anena or Justine or send a chat message if you're having technical issues. I'm going to add their information into the chat box. So you can mute and unmute yourself using the small button at the bottom of your screen that looks like a microphone. We are asking that everyone who is not speaking remain on mute during the speaker sessions. We'd like for you to add your questions to the tab at the top. There should be 3 little buttons underneath where it has the name of the webinar, and the one to the right that looks like a triangle with 2 shapes underneath it. There's 2 things under there. One says polls and one says Q&A. So if you go to the Q&A, you can post a question. You can also post it in the chat box, but we'll be monitoring the Q&A first. So what we'll do is the speaker will speak through their slides, and then we'll open it up to the questions in the Q&A. We'll check the chat, and then we'll go to the phones for those. So you can use this chat function, but this sends it to all attendees for the meeting. You can't send it to a specific attendee with this technology. We do ask that people announce themselves when speaking. So at this time, I'm going to turn it over to Alana Sutherland, who's going to give you a little bit more information about MHCC and our role in PFACs.
Thanks, Melanie, and thank you all for joining us for this event. So I'll start by sharing a little bit about us. We are an independent state regulatory agency responsible, among other things, for supporting advanced primary care and practice transformation. And we do this to promote high quality care that is coordinated, patient-centered, and more efficient. The innovative healthcare delivery landscape of Maryland includes an approach to contain costs for the public while incentivizing better health outcomes through pay-for-performance programs. And in 2014, Maryland sought a waiver from CMS to adopt new policies under the all-payer model and later the total cost of care model. And this approach involves provider collaboration to transform care and foster delivery innovation with a focus on managing and preventing chronic and complex conditions. And 2 of the strategies in the total cost of care model are to support providers as they take responsibility for the care and health outcomes of populations, and ensuring providers, payers, and healthcare consumers are working together to achieve common goals. National and state programs and certifications that include a patient and family engagement requirement are the National Committee for Quality Assurance Patient-Centered Medical Home Program, Transforming Clinical Practice Initiative, and the Maryland Primary Care Program, which is a key element of the total cost of care model, which supports the overall healthcare transformation process and allows primary care providers to play an increased role in prevention, management of chronic disease, and preventing unnecessary hospital utilization. Patient and family advisory councils are a key component of practice transformation, and they bring together the perspectives and patients and families directly into the planning, delivery, and evaluation of care. PFACs provide a mechanism to seek and learn from the patient and family perspective, to promote a culture of patient and family-centered care within an organization, to guide patient and family-centered care implementation through collaboration to improve programs, services, and policies, and to enhance the delivery of high-quality care. In the spring of 2019, MHCC released the PFAC Guide, which is an evidence-based tool that was informed by stakeholders and practices. The guide provides information and resources to help practices create, integrate, and expand a patient and family advisory council. And key elements of the guide include what, why, and how sections that further explain each topic, the impact on ambulatory practices, ask questions, provide additional information to address general practice questions, tips that provide advice related to each of the topics in the guide, and actionable suggestions supporting each topic, quotes from patients and providers, printable ready-made forms and templates, links to resources to support additional education, a glossary of commonly used healthcare terms, and a list of acronyms. And the guide is organized into 3 sections around 3 levels of familiarity or experience with PFACs. The first section is creating a PFAC, which is meant for a practice in the more beginner stages of considering implementing a PFAC. The second section is strategic PFAC integration, which is for practices with a more intermediate understanding of patient and family advisory councils. And then expanding the PFAC's influence and impact, which is for practices with a more advanced understanding who may have a PFAC in place and who might be looking to expand or improve the sustainability of a program. To use the guide, a practice should first select the most applicable section to their needs and capacity. They should review and implement the strategies outlined in that section, and then utilize additional resources provided in the guide for each section to further inform implementation. And the link to the PFAC guide is available on this slide at the bottom, on the bottom of the slide. And MHCC is developing an addendum to the PFAC guide to spotlight considerations related to the implementation of PFACs during the COVID-19 public health emergency. And this will be based on data from ambulatory practices. The development approach includes gathering data from a virtual focus group for qualitative data and an environmental scan to assess how PFACs and PFAs are being engaged during the public health emergency. And we will be sharing additional information and details about the focus group opportunities, which we anticipate to take place before the end of the year. And so now it's my pleasure to hand it over to our presenters who will speak about their PFACs and how they've evolved as a result of COVID-19. First up, I would like to introduce Stephanie Scobie of Ascension St. Agnes, and following that, we will turn to Luminous Health Anne Arundel Medical Center. So Stephanie, I will hand it over to you. Feel free to provide more information about yourself and let me know when you're ready to advance through the slides.
Awesome. Thank you so much. Good afternoon, everyone. So my name is Stephanie Scobie. I am the Director of Care Transformation and Clinical Quality for Ascension Medical Group here in Baltimore. So I am also the strategic lead for our Care Transformation organization, which will be starting in January. We have been doing PFACs for a little over a year now, so we are probably in the late beginner phase of those 3 stages that they were referring to. So go ahead and get started. Give you guys some operational information about our PFACs and how we got the ball rolling. So Alana, next slide, please. So again, here's my name, and then I also have Pooja Patel, who is our Care Transformation Specialist. She is my boots on the ground PFAC person. She's a really key person who supports the work that we do here, and I wanted to give her a shout out as we move forward. So next slide, please. So we began last late summer of last year, thinking about our PFACs as part of the MDPCP program, as I'm sure many of you are. If there are any of you on the call who are thinking of how to start a PFAC or are just getting things going, this is kind of our process for how we got to where we are today. So here's the expectation as defined by MDPCP. That was a starting point for our group. And then we kind of took a step back and tried to think about what was really important to our practices and the communities that we serve. So St. Agnes, if you're not aware, we serve the communities of Baltimore County, Baltimore City, and Howard County, which are very diverse and different. And so we wanted to make sure that we were able to meet the needs of those different communities and address problems or concerns that they had that were very specific to them. Next slide. So as we got started, this was in May of 2019, and I did split it up into two sections here. So this was in the original document, one continuous piece, but so that you could see the detail here. This was how we planned things out. And our group is pretty small. At the beginning, there were just 3 of us that were developing our PFACs. So we all wore a lot of different hats, as you might experience in some of your smaller practices. So we had a physician advocate who is Dr. Ashley Kinder, and then we had the nurse manager for our care management population health team and myself. And this is just kind of an outline of how we planned things through and assigned owners to each of these steps along the way, which we found to be a really important piece. Next slide. So for operationalizing our PFAC, we felt that meeting quarterly was a cadence that we would be able to sustain and that would be meaningful. And again, because we do serve very different patient populations in these counties, we felt that it was important to hold 3 separate PFACs. So each quarter we hold 3 different PFACs that is in Howard County, Baltimore City, and Baltimore County, as I stated. We do have provider representation at each one of these meetings. We have physician leadership. So our president of our medical group attends the meetings. We have our care management team, have a pretty diverse group that come. But we strategically made the decision that for, let's say, our Baltimore County meetings, no one who works in Baltimore County is a staff representative at those meetings, to make a space for the patients so that they could feel comfortable to share any negative experiences or concerns that they had. We wanted to make sure they felt safe. So that was a very conscious choice for us. Timing and location. We have a centralized location for each of those counties, and we really struggled with how to pick the right time. So we ended up doing 4:30 to 6:30. Mostly because we recognized that a lot of our participants were older, and we, in the winter in particular, they might not feel comfortable driving after the sun goes down. But then we also wanted to make it late enough in the day that if any participants were working, that they would be able to join us maybe a little bit late after their workday had ended, if we were able to get those. That time seems to be working really well for us. The big piece for us was the outreach and recruitment strategies. That has been an ongoing struggle for us, as I'm sure other people who have done PFACs may have also experienced. Our biggest source of recruitment, our biggest success was engaging with our physicians and our practices. And we had flyers that were up, and we reminded them every time I saw them, they were hearing me ask them to recruit for us. And they connected us directly with patients that they had kind of prepped beforehand to kind of present the idea, and then we were able to connect with them, and those have been our most engaged patients that we've had at these meetings. So retention has also been a struggle for us. It is really difficult for people to commit to coming to 4 meetings, which is the 4 of that year is kind of what we ask for if you're choosing to join. We do have some that are really successful, and then others we have to just be really flexible about how we approach new recruitment and keeping that moving forward. So another big piece for operationalizing our PFACs is the meeting facilitation strategies, which is something that we found to be really, really important in these meetings. You have to have a really strong facilitator for these meetings. You want to be able to give the patients and the family space to share their experiences and their stories, but that can quickly derail if you're not careful. So having a kind of a structured place for them to say those things, but then redirecting them back into the intent of the meeting is a very, very important piece of that. Next slide. So this is an example of the first page of our membership charter. So every person who joins our PFAC actually gets one of these. So it just goes through our mission and vision. It defines the responsibilities of patients and family members who are choosing to participate, what we're expecting of them. It does discuss the privacy HIPAA piece of that, just as a reminder to them that there is the possibility that we could be discussing things that are fall under a HIPAA, and so they need to keep those within that meeting, and they do sign a HIPAA consent form as well. Again, our goal for our meetings, we're 1/3 staff and then 2/3 patients and family members. That ratio is sometimes a little bit difficult to get because we are still starting off, but that is our goal. And then the last page of this document, which is not up here, but is a contact information for all of our PFAC staff members. So anybody has any questions, they have a phone number, an email, a name, and role, so they can easily reach out to anyone if they have questions. All right, next slide. So as we got started, we really wanted to make sure that our initial agenda was very structured, and we have continued to make sure that our agendas for all consecutive meetings have been very structured. We do an internal patient survey for all of our primary care offices and our specialty practices as well. And so I decided to take that feedback, and there are a section where there's the top 5 places you're doing really well, and then there are the top 5 places where you have opportunities for improvement. I took those top 5 questions and identified consistent themes, and then those were the questions that we used to build our first agenda. So you can see here, this is kind of actually was our very first agenda. So we introduced ourselves and discussed the goal, had everybody sign their participation, and set kind of parameters for the rules of the meeting, as we did at the beginning of this meeting, that we would be respectful and that this was a safe space for people. We found that having really clear goals for each meeting was also super important. And then another piece that we have consistently done that I think has made a really big impact is as we go through each topic, we identify specific action items that we are going to work on over the course of the 3 months in between our PFACs and tie those directly back to individuals on the team, so that someone has ownership of those actions. And then before we make our agenda for the next meeting, usually Pooja, it will circle back with the members who were assigned those tasks and get updates so that we can bring that back to our patients so they feel that we are keeping the loop closed for them on anything that they've brought up. Keeping this agenda really short and structured, as it says here, really, really helps with the meeting facilitation and keeping us on track. Next slide. So one of the big goals and challenges that we faced is teaching participants how to draft clear problem statements. So anybody who has a quality improvement or a process improvement understanding knows that this is something that's really difficult for everybody. So taking the things that they have concerns about and adapting them to be an actual goal that we can work through, that has measurable outcomes and that we have clearly defined what successful looks like for the patients and the family. So we do kind of a really casual PDSA in our PFACs. So if you're not familiar with the PDSA cycle, it's a Plan, Do, Study, Act. And so we help them work through this. We don't actually go into the depths of PFAC because it can be a little overwhelming, but we use this to intentionally guide how we address concerns with our PFACs, and then how we take that back to our teams and try out new strategies that they've recommended, and then closing the loop by doing that study piece and readjusting as we see fit. Next slide. So when COVID came, we actually, our cadence is we do a meeting each quarter. So we had done one in January. We had one scheduled for April that we tried to hold in the way that we had held them before. And we had nobody RSVP, so there were no participants. So we ended up making the difficult decision to cancel that. We did feel that it was extremely important that we continue to try to hold these throughout the rest of the year, despite the challenges that COVID presented to our organization. So We did a debrief after our April canceled meeting, which is something we do actually after every meeting, we debrief, but try to figure out how we could still hold our PFACs in July and what would be the best for our patients and for our staff to make everyone feel safe. So we actually decided to hold a hybrid meeting. So we reserved really large conference rooms in each one of those 3 locations where we do our meetings. We had one PFAC representative from our staff that actually showed up and welcomed the patients if they chose to come. We had some waters, some prepackaged snacks for them. And then everybody from the staff called in and participated remotely. We found out after that meeting that nobody showed up in person and everybody actually ended up just calling in. There were some technical challenges that we had to kind of spend the first 20 minutes working through, as a lot of the people on our call had never used a conference call before or never had participated in any of a Google Meets. So that was a challenge as well. And it's something that we still work through, but I think we've learned how to handle it a little bit better. So we debriefed again after July, talked about the fact that no one showed up in person, and then made the decision for our October meetings, which we just had. And those were 100% virtual. And we had attendance at all those meetings and they were very successful. So for 2021, we are holding a meeting in January again, and we have decided to keep that 100% virtual. If something changes, we're going to kind of reassess as we get a little bit closer. But I think it'll still be virtual considering where our COVID numbers in the state are heading right now. And then the big key from that is we just debrief after every meeting, and then we make a decision and pivot as quickly as we possibly can. And then getting that communication out to our practices. We have 9 primary care practices. Getting that information out to them and our physicians and re-educating them about how we're making these changes has been a big piece of making sure that everyone's engaged and is up to date on the changes. So I think that might be my last slide, Alana. So I don't know if anybody has any questions. I think that's the next section, right?
Yep, so I will let Melanie jump in if she likes, but we'll pause here for questions for Stephanie.
Yeah, so at this time, if anyone has a question, they can add it to the Q&A. I don't see any in there right now. We can open it up to the phones if anyone would like to unmute themselves and ask Stephanie a question. In the meantime, Alana, I think that we have a couple questions for Stephanie.
Sure. So one question that perhaps you could expand on was you spoke about how you determined the topics for the agenda for one of the PFACs coming from that, the survey that you conducted. Were there any topics that you feel would be better suited for say a PFAC in the early stages of meeting versus a PFAC that is more established, or how did you determine which topics were best?
Sure. So of the 5 questions, there were some that we just knew that we would never be able to impact. So like some of our facilities are in offices that are in buildings that we rent space. And so a lot of the complaint sometimes is about the number of parking spaces, which is not something that we could really impact. That did actually come up a lot in our meetings. And, we did circle back and try to make some adjustments for that, but it was really something that was outside of our control. One of the other things that came up was patient education materials, and that is something that we were able to directly impact in a really quick turnaround time for that too. So that was kind of how we focused on that, of what can we do that has a big impact that might not be a really heavy lift for the team, and we kind of walked through some of those options. One of the big questions that came out was concerns about patients being roomed after they've left the waiting room and then sitting in the exam room and feeling like they weren't being communicated with frequently enough. And so we took that back. We have a monthly meeting with all of our primary care office managers, physician leadership, and our directors of operations, and talked about that, shared that story with them. And so the commitment was then made that we would try something new and establish new expectations for engagement with our medical assistants, and that they would check in with the patient after they've roomed them. I think every 10 minutes was the time they chose. And then we took that back to our PFACs and asked if they felt, that worked for them. So each meeting built on the last. And then we would, if they didn't really have anything new to talk about, we would go back to that survey and again, pull out some questions that we felt like might be appropriate. Hopefully that answers your question.
Thank you.
So we do have a question from Shiv Khanna. Would you like to speak your question yourself, or would you like for us to? You're welcome to unmute yourself.
Do you have my audio now?
Yes, please go ahead and ask your questions.
Okay, good. So I see that you've been pretty successful with that. I congratulate you on that. And so we've been trying to do something on a much smaller scale, being a single practice. So develop these kind of agendas and strategies has been kind of pretty heavy lift for small practices. So we're looking for some success stories from out there, and if would it be possible to get an agenda from you, what's your first meeting, second? Of course, we're going to modify it according to our needs and all that, but just to give a roadmap for us to move on to this path.
Sure. Yeah, I'd be happy to share that with you. We have, like I said, we just became a CTO. And so as part of our CTO services for our participating practices, we do provide some templates for agendas and things like that for any participating practices. And we do have some that are small, just like you. I think they have like 500 covered lives, so pretty small. And we are helping them work through that. So I would just recommend if you do any sort of patient surveys, or you have like a feedback box in your office, or if you have some really engaged medical assistants or front office staff, I would ask them if there are some questions that they get really often, or concerns, or maybe complaints that they receive from patients, and kind of work through those with your team first and see if anything comes up from that you think might be a good place to start. Usually the patients that you hear from are the ones that probably will also participate in your PFAC. So there might be a good bridge there for you to connect some of those things. But I would recommend starting small and manageable. As you said, it is a really heavy lift, and building and sustaining the first one or two can be really challenging.
Although I would like to share part of my experience with you guys, if it's okay. And that is that I've been in practice for many years now, over a decade. So even before this MDPCP or MIPS were in play, we had a suggestion box, plain, simple, old-fashioned box hanging on the wall. And we used to open that and take a look at it and address those issues. It worked really well. And so I'm planning to put that back on there. And so can people drop their concerns without being, thinking that this is going to somehow have a negative impact on our relation? That has worked in the past, and I'm hoping that will work in the future as well. So getting to come back to, should we obtain assistance from one of these CTOs? When you have too many parts in a small practice, you lose the essence of it, and then you have several different little parts that come into play, and then you kind of lose track of them, really. So I was hoping, without getting into the CTOs and official relation, we could get some those things, but I totally understand nothing is for free. And so I'll just leave it at that.
So we do have some that are part of the PFAC resource guide that that Alana mentioned in the beginning. So there are some free samples and also references to those. And all of the products by the Maryland Healthcare Commission are completely free public documents. So we're happy to share those with you.
Thank you, Melanie.
So you had another question. Do you want to ask that one about the some of the concerns that patients have expressed through PFAC?
Yeah, I'm just wondering if that, of course, from top of your head, I'm not getting into detail, but do you have any glaring complaint from patients or suggestion that you would like to share your experience with us?
Parking has been a consistent problem for all of our PFACs, and I'm not sure if the Luminous Health team has had any of those.
In Maryland, we got plenty of parking, okay?
Yeah. So signage has been something that's also been a concern in some of our practices as well. That one's sometimes been a little bit difficult. We do own some of the property, and so we've been able to adjust those signage, those opportunities, but some of them, again, we rent that space, and so the landlord is not open to us adding additional signage. Communication is the #1 problem and the consistent issue that has come up every single PFAC. And I think we've held 5 of them now, and that has been a problem every single time. So it's communication between the providers and the staff and the patients when they're in the office. There have been concerns about communication when patients call into the offices. Sometimes they feel that the recordings are not descriptive enough. Sometimes they feel that the person that they might get in touch with on the other end might not be able to give them the answers that they feel like they need in a timely manner. So we've worked to standardize some of the scripting that we have when our front desk staff answers the phones, and then to find a really clear escalation plan for if they're not able to answer those questions, who do they raise that up to in a really timely manner so that our patients don't feel like they're kind of left there hanging, which a lot of times happens, especially if they call after hours and they're transferred to the call service. So communication, I'd say, would be the #1 problem. And so if you had some ideas around that in your office, if you've experienced any issues, that might be a really good place to start.
That's a very good issue. And as a matter of fact, when the COVID started and all of us struggled to get back on the telemedicine thing, we of course had a bunch of emails that were floating, a bunch of phone numbers, even private numbers, and all that was floating and everything was a game. And now when we are into this and we realize that opening all channels of communication to the patient is a double-edged sword. If you miss one channel that they use that is not being watched by you, so you need to limit your exposure routes, okay? And so where you can have a good handle on it. That's my suggestion to the members of this team. I mean, sometimes, well, you know this from your experience, that about 5% of population uses 90% of your resources. And now every day you're getting a 3-page email from people. And at the end of the story, when you read for a while and then you realize, wow, what am I getting into? These are some of the concerns that are not important at all. And some people just use it, of course. I'm not saying that, I don't generalize it, of course. But it is one of the things that you guys all have to watch for it.
And I think that's a really important point, because that's where it comes back to your ability to facilitate the meetings is going to be a really important part, because I think, as you say, those patients, you do get those long emails, but mostly those patients just want to feel heard and they want to feel like they have a space to have those conversations. And so letting them voice those concerns, but in a controlled way so that you don't lose so you don't lose control of the meeting, and then it ends up being an hour of complaints, which is not productive for anybody. So sometimes it requires a firm hand to redirect them back to the goal and to help them feel validated in their concerns. So that facilitation is a big piece of that puzzle.
Thank you, and I agree with you.
So thank you for those great questions and answers, Stephanie. If anyone else has additional questions for Stephanie, you're welcome to send them to Alana, and she will route them to the speakers. So someone added into the chat that they'd like the slide presentation, and we will be sure that the slides are posted along with the recording on the MHCC website. So at this time, unless someone on the phone would like to ask an additional question, would anybody on the phone like to ask anything additional? Okay, I'm going to go ahead and turn it over to Luminous Health, Anne Arundel Medical Center, to tell us about their changes that they've made in response to the public health emergency.
Thank you so much, Melanie. It is my pleasure to be part of this wonderful webinar, and we want to thank the Maryland Healthcare Commission for inviting us to participate. I have the honor of introducing our team, and we're going to start with Monica Mushaw, who is our Patient and Family-Centered Care Coordinator for Luminous Health Anne Arundel Medical Center. We have our phenomenal Pat Holly, who is Patient Family Advisor, who is going to tell her story. And I would suggest that people in the audience maybe get a few tissues out. This should be on the safe side. And then I'm also part of the presentation, and my name is Sharon Cameron, and I'm a practice manager for Luminous Health Anne Arundel Medical Center. I'm located on Kent Island, which is on the Eastern Shore. So without further, I'm going to turn over the next to Pat to tell her story.
Thank you.
Next slide, please.
Thank you. So who knew that this cute little girl in this photo would have a story to tell about patient and family-centered care and PFACs? Yes, this little girl is me at age 5. And I realize now that even then, my life experiences were preparing me for this important work. I'm truthfully not sure how I became a patient family advisor. In 2009, I flunked my mammogram. And after 2 years of surgeries, chemo, infusions, radiation, etc., but feeling very grateful, I wanted to give back, and I volunteered for the hospital's SOS Survivors Offering Support breast cancer program. Someone from the staff apparently recommended me for an advisor role, and as they say, the rest is history. But back to history and this little girl. About a year ago, a few of us were preparing to participate in a national conference on PFACs and diagnostic errors, and I realized I had my own story with patient family-centered care apart from being a breast cancer survivor. You see, shortly after this photo was taken, I started having a series of appendicitis attacks, which were unfortunately misdiagnosed each time. I was born with larger than normal tonsils, and our family doctor kept insisting with each attack that my abdominal pain was a secondary infection caused by my tonsils. Although I was taught not to argue with adults, I finally courageously insisted that my throat wasn't even sore, to which the doctor said, "She's lying." This is a reminder to always listen to patients regardless of their age. My appendix eventually burst, but thankfully my parents took me to a different doctor who examined me in the waiting room, as I couldn't even stand at that point. I was rushed into emergency surgery, developed sepsis, and spent the next 8 days in the hospital. Obviously, I survived, but that series of errors is why my husband and I know why the only children we have are the midshipmen that we sponsor at the United States Naval Academy. As Monica talks about the patient and family-centered principles, I'm sure you'll be able to imagine how my story would have been different if patient family-centered care principles were applied, and why the voice and perspective of patients is so important. Monica?
Hi, good afternoon, everyone. My name is Monica Mushaw, and as Sharon said, I am the Patient and Family-Centered Care Coordinator at Anne Arundel Medical Center. I just want to take a moment to thank all of you for spending your lunch hour with us. I know one more remote meeting is probably not the most fun thing that you could do with your afternoon, but thanks for just joining with like-minded people. I think we all share something really important in common, and that's that we believe that patients and families should be a part of the healthcare team. And some of us are well on our way to making that happen in our organizations, and some of us are just starting on that journey. But I think we can all learn from the time that we're spending together today. So I wanted to just briefly talk about patient and family-centered care. This definition comes from the Institute for Patient and Family-Centered Care. And it's really just a good little phrase to have in your back pocket when someone asks you, what is patient and family-centered care anyway? It takes the old-fashioned notion that we as healthcare providers take care of patients and they should do what we ask them to do. And it shifts it to us working hand in hand as part of a circle of the healthcare team. Patient and family-centered care is not a standalone, it's not a standalone program. What you really have to have buy-in from your entire organization. And this means from the highest level, your CEO, your president, your physicians, your nurses, your healthcare team, and the person who works at the front desk. They all need to be a part of working together for patients and families. Next slide, please. The core concepts, I don't think anyone in healthcare would really argue with these. I think we all believe and know at least the first three to be true. We all know that patients and families should be treated with dignity and respect, right? That goes without saying. We all believe that information sharing is important, that we need to be able to share information with our patients in a way that's useful and understandable in the language that they prefer. And we always want to invite them to participate in their care to the extent that they're able to. It's when we get down to collaboration that sometimes we hit a little stumbling block. Collaboration is what we're trying to do here when we try to bring patients and their families into decision making, into policy making, into strategic planning. That's where sometimes people say, I'm just not so sure about that. Next slide, please. Sharon's going to take this one. Sharon, you just need to come off mute.
So why host the Patient Family Advisory Council? It improves the quality and safety of the care provided. Patients and/or their families provide beneficial insight based on their experience. The engagement of patients and families increases provider and patient satisfaction. It also is very important because it helps us to identify areas that are in need of improvement or refinement. We do the work every day, but we need that input to see where we may be having to just change a little bit of a workflow or maybe just a process so that it's more patient-friendly. And we have to remember, too, that patient family advisors are the eyes and ears of the community. Next slide, please. Monica?
So I have a feeling many of you registered for this webinar today because of the looking back on what happened with the COVID pandemic over the last few months, and now here we sit bracing ourselves for potentially another wave. And so we wanted to share with you some of the core things, the core strategies that we adopted that helped us at our organization utilize patient and family advisors, even while we were in the midst of focusing almost all of our resources on the pandemic. This picture, I think, just kind of sums up just the relationship that we have with our PFAC. This was the first meeting that we had via Zoom. Our oldest member is 82, and he's up there on the left corner, top left corner. And this was his very first remote meeting ever. And our younger members, let's see, are down on the bottom right, and they're in their 30s. We have our president, who is in the middle bottom row, and our chief nurse. And all of our staff were, let's just say, it had been a rough couple of weeks. And the PFAC on their own decided that, they wanted to send us some encouragement. And they made these little signs just saying thank you. And they kind of surprised us during the PFAC meeting. Pat's smiling real big because she remembers, and I think we all just started crying. I think it was really one of those moments where we just felt so encouraged. This small gesture meant so much to us. And so when people get stuck on this collaboration piece, I've heard before people say, a PFAC is just an opportunity for disgruntled patients to complain. Does this look like that to you? No. These are folks who have stood behind us, have supported us, have walked an incredible journey with us over the last 9 months, especially. So just wanted to share that image with you, just as a snapshot of a really special time. Next slide. Following that, our advisors continued to focus on a couple different ways that they could participate with us during the peak of the pandemic. And I'll talk a little bit more about this in a minute, but really there was a lot of the work they had been doing had been put on hold. We were focusing a lot of our resources on just managing day-to-day operations. And so they determined that part of their new mission was going to be just to help support the healthcare staff. And on their own, again, they determined they were going to make a video that we could share with all of our staff. And we just thought we might play it for you. And you could see sort of the demographics of our PFAC and hear from them why they're part of our team.
Thanks. So give me just a moment. I'll cue that up.
As one of the patient family advisors at Anne Arundel Medical Center, we know that you're always there for us when we need you the most. From the hospital's PFAC Advisory Council, other advisors, family, and your friends, we thank you. Whatever your role, you are our healthcare heroes. Then, now, always.
As a mom of 2 boys delivered at Anne Arundel Medical Center, thank you for all you're doing. We love you. Boys, say thank you.
Well, just wanted to say thank you to all the AAMC staff for all you do.
You were my heroes long before there was a pandemic. You have saved my life multiple times, and you have treated me with kindness and compassion. You've encouraged me to live my life to the fullest while coping with cancer. You have made a huge difference in my life. Thank you from the bottom of my heart.
A big shout out to all our healthcare heroes at AAMC, but also all over the world. From all of us, thank you.
Words cannot express how much we thank you for all that you have done and all that you are doing in the future to protect us and our families. Thank you very much again.
To all the healthcare heroes at Anne Arundel Medical Center, thank you for your courage, your dedication, and your sacrifice. Your acts of service is truly saving lives in the community. Once again, thank you very much.
AAMC Health and Heroes, thank you for all of the help and care. Tom.
On behalf of the Behavioral Mental Health PFAC, we appreciate your hard work, your persistence, your compassion. You truly are healthcare heroes.
Hi, I'm Lynn Vosberg, co-chair of the Women's and Children's Patient Family Advisory Council. On behalf of the council, I want to thank Anne Arundel Medical Center's healthcare heroes for what they've done, what they are doing, and what they will do to get us through this pandemic crisis. Thank you all.
On February 27th, I had cervical spine surgery. When I got to 5 North, I was met by a nurse, originally from Kailua, Hawaii. For the next 5 hours, she gave me exemplary care, and she gave it with a beautiful smile and a caring spirit that I can still feel today. She's my AAMC healthcare hero.
To each and every one of you, thank you, AAMC healthcare heroes.
So, and I want to clarify also, we have several PFACs at Anne Arundel. We have just what we call the hospital PFAC that covers our acute care area, women's and children's, which we affectionately call our WAC PFAC, and behavioral health and addictions PFAC. And we're in the process right now of creating a Latino PFAC. And so this was some of the patient family advisors in this video sit on multiple PFACs, but it was just a really encouraging video that really resonated with our staff and just helped lifted spirits Next slide, please. So I alluded to this a moment ago. There was really two methods that our PFAC decided to focus on during the height of the pandemic, that support and encouragement piece, and then also finding new ways to engage with our staff. I'm not going to read this slide. I thought this just might be helpful to look at as you think about how your PFACs will engage with you over the months to come. But I really can't stress just how important that encouragement piece was. There was a lot going on in the community at that, the beginning of the pandemic, just encouraging healthcare providers. But there's something really special about the people that you actually work with, advisors that are, well known at the hospital, to spend their time donating food, donating masks. We'll talk more about that in a minute, and just being present during some of those very stressful times. And then finding ways for people to engage in new ways. This was a first for us, right? We didn't really have a plan for how we were going to do this. One of the first things that we did was when we realized we were going to start seeing more and more critically ill patients, we started planning for how we were going to make them feel comfortable and at home. And food is a huge part of that. So we started working with our patient family advisors, just talking with them about, what do you want when you're really sick? You want comfort food, right? And so what kind of food could we prepare to make our patients feel more at home? We knew that visitation standards were probably going to change. And so we just asked our advisors, like, what is that soup that you love when you're sick? What kind of, drinks would make you feel more comforted? And so we were able to prepare in that way. That may seem like kind of a small thing, but, I think it really just kind of helped confirmed, especially for me, when our nutrition department reached out to get advisors involved. I thought to myself, this really is an organizational commitment at this point. We had to pull small groups together. We didn't have time to make decisions to wait for our PFAC meetings. We had to pull smaller groups together. Sometimes, I would call them in the morning and say, can you get on a call this afternoon? We really need to talk about visitation, for example. As the governor was making his recommendations, we were responding quickly. So we had to have a few advisors who were willing to sort of be on call for us. And not everyone can do that, but we did have a good amount who were able to be available for us. We did some virtual, and at the more of the tail end of the last wave, some in-person role play with our providers, our residents, just to talk with them and do some role play about best practices in communication during the times of COVID. We actually had a few advisors who were hospitalized, not for COVID issues, but just happened to be hospitalized. And so they were able to share their experiences of being a patient when their normal support person were not able to be with them at the bedside, and just kind of how the physicians played into that, and how the physicians could, just opportunities for improvement moving forward. Next slide.
So in looking for innovative ways to help, as a PFAC, we learned that the hospital was doing a community outreach effort to get masks and other supplies into senior and other underserved communities. So PFAC members reached out to our family and friends, and so far we have donated well over 2,000 masks. We just love the message of this t-shirt, so we chose that because we got this.
Next slide. The next couple slides just talk about engagement. So our patient family advisors are engaged with some of our high-level committees and councils. And one of those is our daily safety call. And this is a call that we have every single day with leaders across the hospital. And we talk about staffing and any problems going on. And it's really an opportunity to troubleshoot and get ahead of any issues in the morning before the day really picks up. And one of our patient family advisors was on the call and happened to mention she was getting ready that morning and she was watching the news, and someone from the CDC was talking about the 3 W's: wash your hands, wear a mask, watch your distance. And it was just a very easy to remember, catchy little slogan. And our marketing team got wind of it and decided that this would be a really valuable addition to our patient communication. And so this phrase ends up on a lot of our patient education materials, discharge materials throughout the hospital for our staff to read, and even made it to our Facebook page where you could make your profile picture, use this as a frame. So it was just a great, again, great example of engagement with our organization, that our marketing team is willing to listen to the feedback of patient family advisors. And in this case, very useful and practical input. Next slide. Engagement at the highest level. The photo below is our CEO, Tori Bayless, and to her right is Earl Shellner, who's one of our veteran patient family advisors and sits on our hospital PFAC and our behavioral health and addictions PFAC. And they were scheduled to attend and be the plenary speakers at the IFPCC Institute for Patient and Family Centered Care conference this summer, which ended up going virtual. They were still able to share a lot about what we're doing in our organization in terms of quality, safety, and equity. And the reason I included it was because I just wanted to show how important it is for leadership to be engaged with their patient and family advisors. If I had one take home from today, the only thing you remember from me is that is the secret sauce to a successful PFAC. If your senior leaders are not engaged, your PFAC will flounder. And so I just wanted to emphasize that. And we're very fortunate to have leaders who believe very much that patient and family-centered care is the only way to offer healthcare. But it's great to see it illustrated so beautifully here. Next slide.
Hi, this is Pat again. Our patient family advisors, I think this is key, we are embedded into every part of the organization, including designing and planning for the future. And here we are. I'm actually peeking out from the first 0 there. We're working on redesign and modifying our 2030 plan. Given obviously when we first met, we weren't in a pandemic, so we pulled all the stakeholders together to look at any modifications or innovation that needed to be made. And I think it's really critical that you don't set up parallel systems for your advisors, that you include them in everything. And as Tori, our CEO, likes to talk about this using the Hamilton song, said we need to be in the room where it happens. Next slide.
So some tips. So designate a provider lead. They're so important, as is the senior leadership engagement, and it's the key success to the PFACs, whether it's in the inpatient setting or whether it's in the ambulatory setting. You want to ensure that you engage your staff to participate, to recruit, to identify patient family advisors. Offer Zoom option meetings or some type of a virtual meeting option. People like that. They're getting more used to doing the virtual meetings, or they may want to be on site, but making sure that whatever way you go, that it is safe for patients and also for staff. You want to make sure that you utilize email and phone calls for input feedback from advisors. Stay in touch with them in between meetings. They want to know what's going on. I think one of the hardest things is if you have a meeting and you ask for input and then there's no follow-up. So you always want to follow up with your advisors and schedule your next meeting, whether you're doing it quarterly or whether you're doing it every 6 months. You want to maintain the 6 feet of social distancing for on-site PFAC, and then communicate the expectations before each meeting of starting and stopping on time. HIPAA, have them sign confidentiality statements, and keep it very upbeat and moving, so to speak. Everyone should wear a mask. Have a few on hand just in the event you need to provide them. You want to ensure your snacks, drinks are individually wrapped. So I had an aha moment. I recently joined this practice on September 15th, and on September 24th, we were hosting a PFAC. And, you know, you're used to ordering the cheese trays or you're used to ordering the cookie trays, and it was like, oh, we can't do that anymore. So you want to make sure that your snacks and your drinks are individually wrapped for safety purposes. And then also remember to follow up with your PFAC members to schedule standing meeting times. It's very important. Next slide, please. And in closing, I love this quote, and I wanted to share it, by Mahatma Gandhi. A customer is the most important visitor on our premises. He is not dependent on us. We are dependent on him. He is not an interruption in our work. He is the purpose of it. He is not an outsider in our business. He is part of it. We are not doing him a favor by serving him. He is doing us a favor by giving us an opportunity to do so. Thank you so much for allowing us to participate in this wonderful webinar. And I'll turn it back to Melanie and Elena.
Great. Thank you so much, Sharon. So that was such great information from both you guys. We really appreciate it. So I don't see questions in the written Q&A. So let me go over just some really brief housekeeping items, and then I'll let people who want to stay on the line ask questions because we are right at the time. So the free PFAC guide Alana highlighted is posted on our website. The slides and the meeting recording will be posted to the MHCC website. All the webinar attendees will receive an email invitation for PFAC focus groups to provide feedback on how the public health emergency impacted your PFACs for ambulatory care practices. So at this time, if the Anne Arundel team and Stephanie have a minute, we can hang on for questions that people might have. So Alana, I think we had 1 or 2 questions.
Sure. So I think a good question would be regarding how switching from in-person PFACs to using the virtual platforms may have affected the diversity or representation of the participants on those PFACs. Did you notice a change when moving to the virtual platforms with the people who could participate?
Our participation has never been better. Yeah, I'll say that. We have found that most people by now are very accustomed to getting online and participating in meetings. It's definitely not the same. And there is, we're being very intentional about, you know, spending time just, we have like an icebreaker question where we can just talk casually, you know, a little update about just real normal life stuff before we dive into our agendas. And I think that's really important. We have, you know, you might make generalizations or expect certain demographic groups to not be as willing to participate, but we have not found that to be the case overwhelmingly. But I'm sure, you know, some groups might lose members here and there that, you know, just might not be comfortable with the technology.
For me, I had 3 in person and I had 1 on Zoom. And what we did with the person who was on Zoom, we made sure we set the computer up into an area that they were actually almost a focal point of the room. And we also did an icebreaker, and it was basically tell a fun fact about yourself before we got started. So the group was able to really start to get to know one another. It was really nice.
Great, thank you. So I'll open it up to the phone one last time, and then anyone is welcome to send questions to me or to Alana, and then we can also route them to the speakers. So would anyone on the phone or web like to ask a question at this time? Okay, so someone did ask us about the size. Oh, okay. So here's the question. We've gone to the webinar. So you may have discussed, but how do you determine the size of your PFAC group? And I'll throw that to Stephanie and to Sharon or Monica to say, how do you guys know how many representatives to have?
So I'll guess I'll go first. This is Stephanie again. So we kind of went back and forth between this. Both struggled to find what was a large enough number that you could get a lot of variety in your answers and your engagement, but also keep it so where it still felt pretty intimate. And for us, the number we decided on, we cap it at 10. And we have about 8, depending on like our Howard County practices. We have 8. Some of the ones are a little bit smaller, about 5. So ours are pretty small. I think if we had merged them all into just a primary care meeting, it would have been much larger, but I think we would have lost our ability to have those really kind of down in the weeds conversations with those smaller groups. So that was our choice. And I think it will probably continue to stay at around 8 to 10.
Thank you, Stephanie. Does the Anne Arundel team respond?
From the ambulatory world, I manage 2 primary care practices. So we also kept it small and manageable so that they're able to build that the energy and the momentum as we move forward. I had 4 attend, 3 in person and 1 on Zoom.
And how many providers are in that practice?
There's 6 providers. And so I also had a provider lead. We also had good representation of staff. Keeping in mind when I hosted the first one, I had only been with this practice 9 days. So it was really great. The staff had recruited the patients ahead of time. So it was just being able to go ahead and facilitate the meeting and really pick a topic that was meaningful that we could work on.
Great, thank you. So I'm not seeing any other questions at this time. I'll open up for maybe just one more question from someone on the phone. Does anyone on the phone or online have a question? Okay, so I'm not seeing any. Thank you so much to our presenters for sharing this wonderful information with us. And thank you to all of us for joining our webinar today. Have a great day. Bye, everyone.
Bye-bye.
Thank you.